fair and equitable workplace policies. Thank you again, Calista, for being here, and we're excited for your presentation.
Thank you so much, Elise, and it's a pleasure to be here today. And hello to everyone out there in the virtual world. It is great to hear you, to feel you, to be with you. We have been navigating this for a while, and so we're pros at it. So I thank you for being here, and I look forward to sharing my personal story and journey. So I will start by this. I'm going to let you know that maternity leave is not a leave at all. And it's very interesting because it really goes into my journey and what brought me here today. So I'm going to go back to this slide here. So my name is Calista. I'm known as your talent fairy godmother, making magic for small to mid-sized businesses to keep and retain the best talent. I do that through talent consulting, training and development, and recruitment. But outside of what I do within the work of my business, I've had the opportunity to be a member of part of the Pregnancy Collaborative with the Pittsburgh Study and working with Healthy Start on developing live programming for the betterment of moms in Allegheny County, and also a NICU doula program that I'll talk about throughout this presentation. So I ended up moving to Pittsburgh from Charlotte in 2019. At the time, I was about 5 months pregnant and on this journey. Very exciting time. And it also was an awakening time too, because a year prior, we had an incomplete miscarriage that I had at the beginning of my second trimester. And I actually was on vacation up here when it happened. I was at a friend's like bridal retreat that they had in Nemacolin and had that particular event last for several weeks in time and had experienced different things within my workplace, even with that. And so now, fast forward, to a year and some change later, ended up giving birth to our son, Dylan. And I was late. He was 42 weeks, but the whole journey of pregnancy was very textbook. For me, I didn't have any issues previously. I had no issues with my health or anything like that. I didn't even have like morning sickness. I mean, I had a couple of cravings. Like literally, it was textbook, something that probably is like a fairy tale and not for many people. So it was very interesting to be in this space of what my birthing experience was like, and also him leading up to the NICU. So this is Dylan. He was born on June 20th of 2019. And I put the rainbow there, obviously, because he's our rainbow baby after a storm. And my due date was June the 6th. So, like I said, he was born late. I started going into labor, probably started having like contractions or so on early on, like in the 38 weeks time frame. But once it hit to about 40 weeks, we were at the center, the birthing center, and basically had tried to do everything that we possibly can to engage labor and so on and so forth. Tried a wide variety of things for like a whole week and it wasn't working. So I ended up being admitted into the hospital. And from there, actually labored for about 16 hours on Pitocin, didn't have anything there in terms of any epidurals or so on, and then had it. And then an hour later, ended up giving birth to Dylan. So, how did we go from not having any problems before to a child going to the NICU? And I always wonder this. I think in a lot of ways, there are moms and families that also question, what did you do? So that was something that I did. I assumed that because our son was late, that he wouldn't go to the NICU. I always thought of the NICU being babies that premature, not babies that are full term. And it is very rare that full term babies actually get admitted. Um, so we actually, like I said, gave birth on the 20th. He only stayed the night with us for one night. And then they went off to do the shots and testing and so on and so forth. And from there, it was a awakening when a doctor comes in the room and sits down and doesn't have your baby with you and says, there's some things in the testing that we saw, and so we're going to have to admit the child into the NICU. And we were like, okay, so do we get to see him or anything like that? It was like, no. And I was like, well, you can't just, how are you going to admit our child to the NICU and we can't even see him? So that was another thing there. And that's kind of how it started. So they tested that he had jaundice. And so that was the first thing there. So we got a chance to see him for literally like 5 seconds, and then they admitted him down to the NICU. And so from there, I will kind of let you know a little bit of the story that happened. So when you think about it, okay, you get admitted. They said he would be in there for about a couple days. This is actually all the pictures that I have in this, for the exception of two, are actually real pictures of Dylan in the NICU. So that's him there. So obviously they're putting these Billy lights over the baby. They're kind of in this like dome, and eyes are covered. And so that was where he was. So we just thought, hey, jaundice numbers go up, everything's fine. They gave us a date. So the date was about 5 days after he was born. So on June 25th, he was going to be admitted. I was actually breastfeeding at the time. So was, in the hospital, going there. They do feeds every 3 hours. So I was actually being there, on a consistent basis. So me and my husband were spending about 12 to 14 hours in the hospital a day. So I obviously just being delivered, they let me stay there, 2 days, but then I'm spending all of my time sitting up in a chair. I'm not necessarily resting because we're on the hospital's clock of when they actually come in and do rounds at 8 a.m. in the morning, when we actually need to nurse and so forth. So from there, we noticed something. I noticed around 7 p.m. that he wasn't eating. So in that, I knew that there was something that was a little off. So considering that he didn't want to eat for 3 feeds, I knew that something was wrong, but we didn't necessarily know what it was. And he was really like fussy, but he wouldn't eat. Then my husband noticed there was a tiny speck of blood in his stool. And so from there, we brought it to the lactation consultants thing. We brought it to the nurse's attention. They said, oh, it's probably a fissure. We had already did the evaluation of the paperwork, had already been assigned to be discharged. From there, we went home because we would go home at around 11 p.m. and we would come back in the morning at 8 in the morning because that was when all the doctors did rounds. So we usually left at around 7 so that we could be there, park, and be inside. We got a call at around 6 a.m. the next day, and they said your son had blood in his stool all overnight. And so we have to keep him, and we tested it, and he has necrotitis. So neck is a very rare condition. Neck is actually only generally found in babies that are premature. In what our doctor, Catherine Udeku, let us know, and also the researchers that did some stuff on him from the University of Pittsburgh, he's one of 2 full-term babies that was diagnosed with neck in the last 20 years. So it is very, very rare that he had that. And then also with having neck and being full term, they do not feed you. So you're actually only given IV fluids. And so I wasn't able to nurse him at all. So was also wondering, how do I juggle that, right? What are some of the things that I kind of deal with on that end? So, you can only imagine you just had a child only within a couple of days, and now you're having to pump on this rigid schedule every 3 hours. But then you're in the hospital and you're not giving any, we didn't have any vouchers for our car to do parking. We didn't have any vouchers for food. We weren't able to stay in the hospital. And so that can also be very taxing on you, especially when you're nursing. You know, you need to eat on a regular basis and have snacks and so on and so forth. So we spent a lot of money while we were there. Luckily, we do have, you know, a village of friends that brought us lunch at once a day. But in terms of breakfast, snacks, dinner, we were, you know, having to go out and buy it ourselves. So that also creates a strain on you mentally and so on. But then also with being in a space of actually nursing and then having to stop when the baby is so young and you're also getting used to it, I had to just really be on a schedule of like power pumping to produce milk, but then also be in a space where the hospital froze it. So that way, when he could have food, we were able to give it to him. So, one of the things is you don't expect for your child to be admitted into the NICU. And it also can be like a very overwhelming situation. So you can see, like, my husband is tired. We're, you know, tired just being there on a regular basis. You're also not in a space where you can like hold your child um, in the way that you would want to. I remember how different it was when we actually got home because Dylan was so used to being attached to stuff. When we would just even go to reach in with our hands, he would automatically like cry or flinch up because they were, you know, pricking his hands or arms or everything on a regular basis. But I would say also just we realized that we were a little bit fortunate, right, to actually be there. There are some families that were there who they lived in West Virginia or they live hours away or they didn't even live in the state. So to be able to be there every day, but there's not necessarily accommodations for people that aren't. Then, on the other hand, when you think about it, there's not a lot of support in reference to your child's condition or things that you have to know. I mean, we were like researching stuff on a regular basis when we were there, certain things that the doctors told us. You know, it got to a point where Dylan, I think after a couple of days, they wanted to check his blood sugar and they were doing it every 2 hours. And you know, Demetrius did some research and was like, that isn't something that you need to do anymore. So can we stop? Because this is an extra prick that it doesn't need to happen. So really we were being our own medical assistants at the same time to find out care that we didn't necessarily know of because we were in a situation where we hadn't had a child in the NICU. We hadn't had a child before. So it was very new to us and it was very daunting at the same time. So, you know, like I said, you can only imagine kind of only having one, you know, night being spent, right, with your child. You're also trying to also navigate the stay. There's no accommodations from an end of food or parking or so on. And then you're still having to pay really close attention to what the care of your doctors is. And I think for me as well, when we talk about like health equities, we got questioned a lot about whether or not he was his father. We got questioned a lot of times about, you know, well, we can only give information to the mom and not necessarily like someone else. And so we had to navigate also saying that, yes, we're married and this is Dylan's father, but also understanding those type of challenges as well and stereotypes that are given because I know for a lot of individuals, um, having like a male presence and a black male presence was very different. And so we did find ourselves tackling that in a lot of ways as well. So the return back to work, was very interesting. And actually, Demetrius took this picture when I was asleep because I actually was on the computer doing work, having to nurse him and falling asleep at the same time because at that time he was waking up like every 4 hours when we got home. So because I was a new employee, I was only given 6 weeks off. I didn't have any accrued PTO. I did not have any FMLA. So, with that being said, I returned to work 3 weeks after Dylan got released from the hospital. So, not only are we in a space where we have a new baby and we're having to navigate that and also navigate his care outside of being in the NICU, we only had 3 weeks home with him. And which is why I said maternity leave is not a leave at all for some parents because I had to go back to work. And so the job that I had, you had to actually book birthing pumping rooms and you had to actually reserve it. Well, prior to coming back to work, I tried to actually contact the work partners and the different HR individual representatives to find out, hey, I'm nursing, I have this child. How do I actually kind of navigate what that looks like for being able to nurse and pump while I'm at work? And they just told me that I had to deal with it when I got there. So when I got there and I saw a pumping room open, I went in there and I set up all my equipment and was ready to pump and was pumping. And then 10 minutes later, got a knock at the door. And someone said I had this room booked. So I literally couldn't pump that day. And for me, because Dylan had neck, he had a intolerance to certain foods. So throughout the whole process of him being released from the hospital, anytime that we saw something with a speck of blood in his stool or anything like that, he was fussy or so on. It was automatic we had to go to children's because they had to run all these testing because they didn't know if the neck was returning. And so it took about 3 months before we realized that his sensitivity was in the foods that I was eating. So I had to cut out soy, dairy, egg, nuts, everything. And he could not take formula. So I had to pump. So being in a space where I wasn't able to pump, it was almost like I felt like I was starving my kid, and I was because I was missing a meal that I had to give him because that was the only way he was able to get food. And so that also is really challenging. Also, being in a space of being off site sometimes where I wasn't in my actual office, where there was only one pumping room in that whole entire facility. And so it made it really challenging as well. Also, to be in a space where there weren't additional accommodations that I was given in my work because I was a new employee. And also, there's no real accommodations that a job gives if a mother and or a child or a parent has a kid in the NICU. So that also adds a whole nother layer to it as well. So some of the recommendations that I have in reference to what I would consider to be things for equitable workplace policies is, create provisions for mothers to have childcare um, and to have special care with kids in the NICU. There are some parents who may not have a kid in there for 3 weeks or a month like we did. And there are some parents that have kids in there for a few months and even longer than a year. And so I think that once a kid gets released from the hospital, and also even while they're there, they need the support that they need to have to be able to provide to that child. I know in my particular situation, Dylan was born with 2 digits on his finger. It's hereditary on my maternal side, which means that he had 12 fingers instead of having 10. And with that being said, they do surgery on it. One ended up falling off, but the other one we had to have removed. And so, even that was a surgery that had to be in the hospital and so on when he was 3 months old. And then also being in this space of having to, every time that we were going through the ebbs and flows of this dairy intolerance and so on, being in a space of actually having to constantly go to multiple doctor's appointments and multiple visits, going to the hospital in the middle of the night and not returning until 1 o'clock and having to go to work the next day. Just making sure that workplaces and organizations are more accommodating to kids that are having special needs or NICU care. Another thing is vouchers. Having a child in the hospital is very costly. I can tell you for the 17 days that Dylan was in the hospital, that bill alone was over $165,000. And I can only imagine what that bill is like for parents that have a kid in there for 6 months, for a year, for longer than that. Luckily, someone, when we were in the hospital, told us to apply for assistance because regardless of what your income is, if you have a child in the NICU, you can qualify for it within Allegheny County. And I'm just glad about that because anything that our insurance didn't cover, they took care of the bill. And that was a saving grace because I do not know how a bill that high, we would have been able to take care of it in terms of all our regular expenses at the same time. And for parents that have a kid in there for longer, it can be insurmountable to what that can do financially and crippling your family. So having vouchers to help provide parking and food and resources and support is very imperative. Providing counseling on site to families, birthing is a very physical, mental, emotional process, but then also kind of navigating your child being hooked up to all of these machines, not being able to hold them or nurse them or feed them in the way that you would like to, and what that actually does to you, but then also being in a space where you're having to research conditions on your own that you know nothing about. And you're only in these rounds where these doctors are talking to you for about 5 or 10 minutes and they're going to the next table over. So that goes into my next part. I believe that NICU doctors should offer telehealth rounds because there are certain situations where a parent may not be able to be there. The rounds that the hospital did, like I said, was only 1 hour where they went around to every individual patient and just discussed the care and the different recommendations and what they were going to do. But for some people that work in the morning and you have to go back to work, you're not there. And so I think being accommodating and providing alternatives for different times that those rounds could be, and also doing things in the morning or telehealth would be very helpful to families. Work accommodation. So, even after a kid is released from the NICU, there's just a lot of extra care that has to be done. Every little thing that happens, right? If a cough has something, or you say that the kid is fussy because they've been in the NICU, that automatically is like, well, we have to do more extensive checks and research than we would for other people. And I think making sure that the workplace is being able to be accommodating to help families go to those doctor's visits, attend those surgeries, be able to have the work flexibility is very important. So one of the things that I'm very excited about is being able to have the opportunity to work with Jada, who's the Chief Executive Officer with Healthy Start, Dr. Aname, who is at UPMC's Children's Hospital, and Dr. Paris, who also is at Children's and Presby on the NICU Doula project. And so it's really exciting because I believe that this will be an opportunity to catapult the way that we actually support mothers, families, babies in the NICUs, especially women of color that are definitely at a higher rate facing different things. And then also to have a child in the NICU, it affects you as well. So one of the things that it is this particular project is going to be a postpartum doula program, which basically is going to pair families with a NICU postpartum doula to be able to be a support to that particular family during the NICU and doula process. So you think about it. I mentioned about how me and my husband were spending 14-hour days in the hospital trying to navigate how our son's condition was and what that condition was. But at the same time, I got no rest. And, there's certain conditions that I still am dealing with physically. I have different things that still, Dylan will be 3 in June that are coming up, and they maybe started from the time that he was 5 months old, and I'm still dealing with it. And I always wonder, like, what if I actually had the proper rest that I needed? What if I actually had the opportunity to have someone to navigate some of those things in the hospital, and I could actually take time of my physical health and my body, and how my partner would have been able to assist me in that way, and that could have alleviated a lot of physical things that I'm still currently plagued with to today. So really, this NICU postpartum doula program will provide an opportunity to be a total support to families as they're adjusting through that life and the parenting aspect of it. So one of the things that we are working on is to develop this neonatal kind of doula training where Healthy Start doulas will be trained on various conditions, the environment of what the NICU looks like, different health conditions that are out there that are being affected by individuals. We'll go into community listening projects, which is actually going to talk to mothers like myself and also community members, healthcare providers, to really understand what do you actually need as a NICU family. When your child was in the NICU, what do you feel like you could have got that you would have loved, and what maybe could have helped you provide more support along the way. Then the postpartum doulas will be doing like clinicals and rotationals, and also getting extensive training working with the infant families in concurrent with each other at the same time, and that will take about a 2 to 3 month process. And then the NICU support, right? So providing that ongoing support while the child is in the hospital, being able to make sure that they are providing that resource to the family and the baby, but also really being just that guiding force during a time that is extremely difficult. And so looking for this to actually be something that is a model in one particular area, but then hoping that this ends up being across all county hospital systems once we get started. So this is me being very excited, ringing that bell when Dylan actually got released. And the whole goal is to welcome the baby home, but also be in a space to where smooth transition for the families. The one thing is that in the conversations that I've had with Dr. Anime and Dr. Paris is that a lot of times babies are released from the NICU, but then they go right back because the family is not able to be in a space where they're able to really fully understand the child's condition, really know how to take care of the child by the time that they get home, and they end up going right back. And so, one of the things that this will also help is once the child does get released from the NICU, that postpartum doula can still work with the family to make sure that they're making sure that the child is safe and sustainable and that they're able to live a healthy life even outside of the hospital. So that is all that I have for you. And if anyone has any questions, I am happy to answer.
Thank you. Thank you so much, Calista, for sharing your journey with us and the journey that you continue to be on. It's very inspiring that out of this journey, you're creating this amazing program which will help families. Can you tell us a little bit about when to expect the program to begin?
Yes, that's a good question. So one of the things is starting sometime in like the spring, probably like April, Mayish time frame is when we're actually going to start kind of rolling out the how we're going to actually navigate the training and simultaneously like doing the listening sessions. So that is kind of, we're in the infancy stage of kind of gathering more details about each individual part of the 4 pillars that I mentioned to you. And so hopefully in the spring, by the summer, we'll be able to like begin the rollout of what that project will look like.
That's excellent. Another question, I noticed that your care team that you shared on the slides is made up of Black doctors and Black healthcare experts. Can you share how being surrounded by a team of Black experts has been supportive in your journey?
Yeah. So, one of the interesting things is Healthy Start was definitely a big impact. And I saw something with the question there in terms of the Pittsburgh Brown Mamas, I mean, the Pittsburgh Breastfeeding Circle as well was very big. And so, one of the things is it was really great to be a part of those communities. Like I joined the Pittsburgh Black Breastfeeding Circle before I even had my son. And so during the time of navigating like how to nurse while I actually had him, and I ended up nursing for a year because of his kind of condition and also him having an intolerance as well. And so one of the things is it was very helpful to have the Healthy Start consultants that I was able to call on the phone, come to the hospital, also be there when I actually got home. That was very helpful as well. Also being able to have other people come to the hospital and say like, hey, they're telling you that you can only pump for 15 minutes, but you can pump for a whole 30 minutes, And so those are things that I didn't know, but it was very helpful because I was able to make sure that I was producing enough so that when my son was able to eat, that he had it. But it was working with Dr. Anima and Dr. Paris has been very inspiring because they weren't doctors that I saw in my particular experience in being in the NICU. And so I think about, their research and what they're doing and our conversations and meetings that we're having. And I'm like, wow, if I had this while I was actually in NICU care, how that maybe would have impacted the support that I felt like I had and what I felt like that journey was like. So it has been really amazing because they are doctors that are really changing the landscape of what infant care looks like. And so I really know that this is going to be like game changing for this county and this region. And there isn't a program like that exists. There are certain organizations that actually do NICU doula programs, and they're like in California or Texas. There's like one hospital that has established something like it, but other than that, it's not even something that is really even done on a national level, let alone like hospitals that are doing this. So I think that this can really actually be a model that could be instituted like across different states too.
Absolutely. And I think this is a great segue into the next question, because, of course, these ideas and initiatives are excellent, but they cost money. And so, question for you, how is the program going to be funded? And what thoughts do you have on how programs like this should be funded moving forward to make sure that they're scalable and sustainable?
Good thing. So we are working on, Dr. Onaman, Dr. Paris is kind of, and which is why we're making sure that we're rolling out what we need to in the correct way, because they're actually going to be looking for like grant funding and different funding that is out there to actually fund the program. And so they have some ideas of what programs to apply for that. So that is what we're going to do, is to apply for different grant funding and so on, to be able to kind of fund the start of the program. But I believe that there is a lot of work that needs to be done. Obviously, we understand that in this county, it's 6 times higher with the infant mortality of Black women. And there is a lot of programs that already exist to make change and create that particular change. And so I believe that's why I'm glad to be working with Healthy Start and know that this is a great opportunity, which Healthy Start is already out in the community doing things around this work. And I think combining that along with doctors that are already working there, and myself kind of having that experience of dealing with the imbalance of kind of what the work life looked like from an aspect of being a parent and a mother, that we kind of are touching all these different angles of looking at the care.
Excellent. So let me see. I'm going to double check the chat, and please feel free to join or to add your questions to the chat if you have additional questions. And in the meantime, I do want to ask, so I heard you say in the beginning that you were transitioning to Pittsburgh when you were pregnant. And one thing we've been talking about over the past couple of days is just raising awareness. We were talking a little bit about the hidden gem syndrome of Pittsburgh, where there's so many great programs that exist, but unfortunately folks don't know about them, and then you find out and you're like, wow, this is a hidden gem. So can you talk a little bit about how you became connected? So you referenced the Black Breastfeeding Circle, and then even some of the other organizations you got connected to. How did you find out about them, and what ideas or recommendations do you have about just really building awareness of these organizations so that families know that they exist?
Yes, very good question. So I am naturally a researcher at heart. I will find what I want to find that is out there. I'm an avid Googler. I do not know if that is a word, but I'm going to use it, and I made it up. So I just Googled like moms groups in Pittsburgh, Black mom groups in Pittsburgh, moms and Black women, like every word combo that you could think of, I just put it together. And I found a lot of different groups online. And so I even reached out to some of the groups before I moved. I remember, having a conversation with like Muffy from the Pittsburgh Brown Mamas and like Pian and Ghazi about the group, meaning like, hey, I'm pregnant, I'm moving here. So how can I kind of get, established in your community? So that was how it ended up happening. And then I participated in some of the events in person once I got involved. And then over time, right after I had my son, then I was able to kind of navigate those different things. So, talking to Ngazi when she actually came to the hospital to be able to talk to us when he was in the NICU and say, Healthy Start actually has a program to help women with like nursing, and they'll come to your house and so on. So just finding out about those resources and then actually being able to tap into it in real time was how I got engaged. And so it's really interesting to how I see things happening now in a full circle, because I'm getting a chance to work with Healthy Start, but they were actually one of the first organizations that helped me, like when my son was released from the hospital.
That's excellent. Again, feel free to put questions in the chat. If you have questions for Calista, we can absolutely drop those in the chat as well. I did want to follow up and ask you, it mentioned at one point that there was a program that it helped to offset the cost of what your insurance didn't cover. And I thought I heard that you say it was county based. Can you talk a little bit about that program?
Yeah, it was WIC. So yeah, it was WIC. So really, um, uh, when they gave us the discharge papers, they had let us know that you can qualify for WIC. And I guess it's automatic because they had said WIC has different components, right? You can get access to the services to have, like your foods and so on and so forth, but it's income based. But they said, well, when you have a child in the NICU, you can actually get access to have WIC and also have the health component and it's almost automatic. So they usually will send in the information when a child is like children that are in the NICU, and they'll send the information in. So when we actually happened to go to the WIC office, they had actually let us know that Dylan already had insurance under WIC and we didn't even know. But they said, well, the hospital sent it to us. So, but here's the kicker. A lot of times, which this is what the person had let us know that was at the hospital, a lot of times people don't do it because they won't even go to that initial WIC appointment because it's more so of like, I don't qualify, I'm not going to qualify, and they'll bypass it and they won't even go. We saw, okay, well, this is a free resource, but then also there was a little mention of maybe something about insurance, but we were like, let's just go check it out. And in doing that, it was the supplemental insurance that we had access to, which was access, which there's different components that you can have, like UPMCU and some other ones. There's like 3 different ones you can choose from, but it covers all of your child's medical bills that isn't covered by your like insurance. And so obviously once your child gets to a certain age and you have to reapply, maybe at that particular time, right, you may be in a space where you might not qualify, but initially you can actually get access to that. And I know if we didn't go to that particular appointment, we would have missed out on having the bulk of our bill being taken care of, like by this supplemental insurance. So I recommend, regardless of what your income is, whether you feel like you meet the threshold or not, if something like that happens to a family, take advantage of it. Because I mean, getting hit with $100,000 plus bill can be very detrimental to your financial health.
Absolutely. There is a question in the chat. It says, Calista, can you speak on some specific areas of support a new mom may need as her baby returns home from the NICU? And what supports might extended family members need?
That's a good thing. One of the things was, I would say she needs food. That is big. So, I mean, if there's a way that you could set up a meal train, I didn't even know about meal trains until like 2020. And I was in a group and had mentioned that I had to have surgery. And they had said, oh man, let's do a meal train where people can sign up to send you meals. And I didn't even know what that was. Wish I would have when I was pregnant. So I would say definitely do like a meal train, because when a kid comes home from the hospital, it's an adjustment, but when a kid comes home from the NICU, it's a real adjustment. So just being able to establish like a good like sleep routine was something there. And luckily he was a really good sleeper. Didn't really have too much to worry about there, but it is an adjustment, right? Because now your child doesn't have to be on this every hour. Somebody's poking them and somebody's checking them and somebody's testing them, and you know your baby has to feed at these times. Now they can kind of establish their own routine in their own space. So I would definitely recommend, like, if there's something you can do for a couple weeks, a couple months, even extended family, like taking care of food, that is really helpful. Even having someone wash clothes and fold clothes is extremely helpful. Having somebody set up a cleaning service to come to their house. I mean, these are basic things that a lot of times, you know, you normally do, but when you come home from the hospital and I just need somebody to clean my bathroom, or I just want somebody to wash dishes. Those are definitely things that extended and other family can have as well. Especially when you have a little one that has been in the NICU, um, having one point person kind of let everybody know what's going on is very helpful. It's very daunting when you have 30 people calling you every day asking updates. They want to know, how's Dylan doing? How's the baby doing? What's going on? And you're having to kind of navigate that. And so having one person, so it got to the point where like I stopped answering my phone. I just kind of let like my husband kind of take on like this is the update for the day. And we just did that one time in the day. So it was like, this is a text message. We had it sent off, and then it was like, send to these people. So I think that that's helpful because there's so much stuff going on and you're exhausted. And, you either have a child waking up every couple hours or so on. So I think being a little bit more lax and more so just letting the family let you know what they need, but not necessarily overwhelming them so much with just like, oh, can you send me pictures? Can you send me videos? Can you send me this? Because sometimes they just want to rest.
Absolutely. Absolutely. And also just asking about you. It sometimes feels that after we have babies, it's like, do we even matter as people anymore? Like, how are you, mom? Or somebody walks in the door and grabs the baby and you think this kind of breeze right past you. So absolutely
I
important
agree with
things.
that wholeheartedly. And I think in a lot of ways, naturally people do that. They won't ask about you, even as the kid gets older. Like Dylan is great. He's thriving, doing amazing. And, he's 2 and be 3 in June. And trust me, people call, family calls, like, let me talk to Dylan, put him on FaceTime. Let me see, what did he do today? What did he eat? I'm like, is somebody gonna ask me what did I do, or how was my day, or what do I have going on? So I think that that is one thing that I would recommend too. Like really check in on the mom, see how the mom's doing. Book her a pedicure, let her get her hair done. Book a prenatal massage so that she can get one and relax. Maybe take the baby away for a couple hours so that she can, have some alone time and get some sleep. So definitely make sure you ask about the parent.
Absolutely. So, as we get ready to wrap up, I want to give you an opportunity to just share your final thoughts, anything you'd like to let us know, and also just to tell us where we can continue to follow up on information about your program.
Yeah, no problem. So I would definitely say just examine and look at where you work, examine and also look at the places that you want to work, and look at the businesses and the organizations that you have employees, and really take this particular presentation as a way and a light to provide more access to parents that have children in the hospital, babies in the NICU, children with special needs, and then just be on the lookout for the development of this program through Healthy Start. That is who it'll be through, and so really just staying up to date on the website, checking out social pages from there, and that'll be where you'll be able to find updates.
Thank you so much, Calista, for this amazing presentation and for being so open to share your journey. Just in looking at the comments, there's a comment in the chat that just say, mamas need so much extra postpartum support. And then just sharing some resources, programs like this, and then also the NurturHer app, self-care housekeeping, and just needing to change the entire culture around taking care of mothers and babies. And so we thank you again for the work that you're doing and excited for the way that this can transform maternal and child health.
No problem. And I'm really excited too. I wrote a blog about this story on Mother's Day, and it was a year after Dylan was born. And so it's interesting to kind of see just that story of me wanting to share insight on this in 2020 and what it has been able to like birth and do. And so my ideal and goal was for it to be able to help other moms, for it also be able to provide better practices within employers, and hopefully be able to change outcomes for families and babies. So thank you so much for allowing me to be here.
Absolutely, and thank you. So we'll be back at 5 o'clock for our next session. That'll be public interventions for birth equity with Dr. Noble Maseru. In the meantime, please visit healthystartpittsburgh.org/infant health equity. If you visit the page, there is an opportunity to take a survey. We'd love to hear from you as we continue to formulate our action plan. So please feel free to give your input on the survey. And then also we'll have a public input session on March 14th from 5:30 to 7 for you to weigh in on that plan as well. And there's a registration link there. We'll drop that information in the chat, and we'll see you again at 5 o'clock for our next session. Hey, welcome back, and thank you again for joining us this evening. We're getting ready to move into our second session for today. We're joined by Dr. Noble Maseru, who will be talking about public intervention for birth equity. As a reminder, please put your questions in the chat for our Q&A discussion, and you can also visit the Healthy Start page, healthystartpittsburgh.org /infant health equity to fill out a survey to weigh in on our action plan and also to register for our public input session on March 14th. I'll turn it over to Dr. Maseru, and thank you again for joining us.
All right, thank you, Elise, and good evening, everybody. First off, I want to thank Jada and actually applaud Jada and her team, their leadership for infant vitality, birth equity, and reproductive justice in Allegheny County and the city of Pittsburgh. They're doing an extraordinary job. Also, I would like to say thanks for the invitation to share our work and our thoughts in what we've done during our service in Cincinnati in achieving birth equity. And I say achieving, not only advancing, but achieving. But we'll let you be the judge of that. So also, I'm going to dedicate our talk to Miss Annie Barnes. Annie Barnes was the ombudsman to the community in our state WIC program in Georgia. To dedicate our talk. And so Virginia Floyd, Dr. Floyd was the director of the maternal and child health division in Georgia, and I had the pleasure of being the state director, and Ginger had appointed Annie Barnes, Ms. Barnes, to be the ombudsman. So we had a community person who was actually embedded in our state WIC office. Also want to dedicate our remarks and talk to Marcellus Lewis. Brother Marcellus was a leader in health professions education in Atlanta, Georgia. And so our tenure in this work, and if you could advance slide 1, please. And so our tenure spans more than, say, 45 years, but the time that I'm going to more or less share with you today is during our period as the health commissioner in Cincinnati, where we served for 10 years. The general average tenure for a health commissioner is 3 years. And preceding our time in Cincinnati, we also was the health officer for the city of Detroit, where we had the Healthy Start program. So we were definitely extremely a fan, if you will, of Healthy Start. And in Cincinnati, we more or less had both the WIC program and the Fetal Infant Mortality Review, or FEMR. The Cincinnati demographics, Cincinnati is a city about 302,000, about the same size as Pittsburgh. In terms of the racial demographics, Pittsburgh has about 12% is African-American population. In Cincinnati, African-American population is 42%. Allegheny County, I said Pittsburgh, African-American population is 23%. And for Allegheny County, I believe the African-American population is around 12%. The county that Cincinnati sits in is Hamilton County, and the African-American population there is 26%. Next slide, please. And so we more or less had a department of roughly 450 employees. Our annual budget was $50 million. And so every day we saw physically in person, not a phone call, but every day we saw roughly 3,100 persons per day. And I'm bringing that to everyone's attention so that you can get a sense as to the intensity, or at least the degree of what's taking place in terms of a health department, that it's not solely around issues in terms of environmental, but also involves surveillance, et cetera. And so the next slide, please. So the principal values that we more or less had ingrained in the department was that equity in health services delivery. And we're also looking at not just the quantitative issues in terms of numeric improvements, but also the qualitative improvements in health and social well-being of communities, not individuals, but of communities. Also, social justice was a principal value in our department. So when we're talking about social justice, there's generally two features in social justice. One is equity, of which Calista talked or referenced quite a bit, and the other is democracy. The other piece in terms of our values in the department was team management. So we had a more or less, not a hierarchical approach to management and working together, but we had more or less an interdisciplinary. So we would have environmentalists, nutritionists, physicians, social workers who would work on the same team. Next slide, please. And so to get a sense as to what's taking place in a community, in a city, we more or less had to become acquainted. We arrived in Cincinnati in 2006. And so the 13.6 IMR that you saw on the screen, that is what the infant mortality rate was for the city of Cincinnati. This screen here more or less shows in 1956 where most of the births took place. And if you can see, the Cincinnati General Hospital was where the location where persons of African descent were more or less birthed. The other hospitals literally essentially didn't provide obstetric services to the African American population. So it's important to get a sense as to what the history is, what the social conditions were in the past. And next slide, please. And so here we have we had 5 primary healthcare centers in Cincinnati, and when we arrived, and when we left, we had 22 health centers. So this is an example of one health center of the Price Hill Health Center, and we more or less singled this health center out. This is in 2010. And so you can see that the infant mortality rate for the clients that were at the Price Hill Health Center, and just to get some sense here, is that our health centers provided the gynecological obstetrical care, both prenatal and postpartum, in our health centers. We did not deliver the babies. We had a partnership with the university hospital who actually did the deliveries. So what this slide shows is that there were 161 mothers who gave birth and delivered at the university hospital, and the infant mortality rate, as you can see, was 1 death, or 6.2. So you're going to see several different numbers, or hear me talk about, or at least reference several different numbers. And so for the city of Cincinnati, you can see that number for the city overall, the IMR, infant mortality rate, was 13.6. Okay, and for all of our CHD health centers, the IMR was 9.3. So let's give you some sense as to what does that mean? What does 9.3 mean? So for the Healthy People 2020, that was the infant mortality target. The goals for Healthy People 2020, the goal was essentially 6 infant deaths per 1,000 live births. Okay, so you can see here at Price Hill that we actually achieved the Healthy People 2020 goal for infant mortality in 2010 for that particular health center. However, for the city overall, the infant mortality rate was 13.6. All right. So our job, our responsibility as a health commissioner is not necessarily just be concerned about what's taking place at our health centers. We also want to say, well, look, we have a responsibility for the city as well. Next slide, please. Okay, so here you, Calista referenced the WIC program, Women, Infants, and Children. So given our experience, as I noted, as the state director for WIC in Georgia, I was extremely knowledgeable about the benefits of WIC. And so when I went to Detroit as well as Cincinnati, when I discovered that, oh, gee whiz, we had the responsibility of the WIC program. Well, let's see what's going on. What is it? How are our clients faring in the WIC program? So you can see here for the WIC clients, if you're African American, the infant mortality rate is 9.1. The WIC clients, this is for years 2006 and 2007. So with the WIC clients, for the white population, if you're on WIC, you had an infant mortality rate of 6.3. For those who were on the WIC program, if you were not on the WIC program, African Americans, IMR was 17.0, and for the white population, 7.5. So straight away, we could see that WIC is an intervention that really pays off, but if you're African American. So next slide, please. So then we fast forward to 2009, we did a paper, more or less, that to look at what was the impact or the influence of the WIC program in those subsequent years. This is a paper that was published with the American Public Health Association. And so what we determined, our primary finding, was that for everyone that was on WIC, the infant mortality rate was 8.0. If you were not on WIC, the infant mortality rate was 10.6. And if you were African American and you were on WIC, the infant mortality rate was 9.8. And if you were not on WIC, for an African American, the infant mortality rate was 21.0. Again, so this affirmed the benefit and the efficacy of the WIC program. And so for those of you who don't know, the WIC program provides nutritional supplements. It also provides the breastfeeding education. And additionally, you also have the benefit of prenatal care. Next slide, please. So looking at the results of those mothers who were served in our Cincinnati Health Department health centers with our partnership with the University Hospital in terms of the deliveries, we could see for these 3 years, 2012, 2013, and 2014, the infant mortality rate for African Americans was 8.1 for that 3-year period. Hispanic population, zero for the white. And so the overall infant mortality rate for our clients who were served in the health department centers, the IMR infant mortality rate was 3.9. Remember, the Healthy People 2020 target was 6.0. So here you can see that for those clients who participated and frequented through the health department centers, we surpassed the IMR for Healthy People 2020 on the aggregate for 3.9. and for the African American population was 8.1. Now this is 2012, 2013, and 2014. Remember, 2020 is the target for Healthy People 2020 for 6.0. Also keep in mind, or we want to draw your attention, is that what are the demographics of the typical client that's going to go to a health department? Those individuals are either persons who are marginally employed in terms of income, they're working class individuals, they're not affluent, they're not middle class. Of course, we had a couple, 2 or 3 that are, but for the most part, the client population in a health department are individuals who are Medicaid eligible, individuals who are may not be eligible for Medicaid, et cetera. Next slide, please. So what we decided that, look, if we're having these kind of benefits in terms of reaching Healthy People 2020 goal before that particular period, however, we know that the city overall IMR is in double digits, 13 and 12, and also as high as 20 for the African American population. What is it that we can do in terms of importing or actually exporting the work that's taking place within our sphere of the health department? How can we replicate that or expand that out into citywide? And so what we decided to do is that through having discussions, et cetera, is that we more or less developed what we call the Infant Vitality Surveillance Network. And this network more or less provides real-time, flexible upstream intervention opportunities. And it also has a field intervention component. Next slide. And so in terms of the core components of the IVSN, the Infant Vitality Surveillance Network, the core components is what? Monitoring and surveillance of data, care coordination and home visitation, and also what is the care experience of that mother, of that family. Given the time for each one of these particular slides, I'd like to impress upon you is that there is a process, there are protocols, there are forms, there are things that we have in terms of an infrastructure that makes this work. And at some time, if someone would like to have some details, we can bring in staff that can provide you with the forms and provide you with the additional consultation. It's not going to cost you a dime. This is for service to the people. And so next slide, please. And so the Infant Vitality Surveillance Network, and I'll just say IVSN, all right, for the sake of time. What did it exist of? So what we did is that we had a collaboration, and collaboration is key. It's essential. This collaboration comprised of the University Hospital, UHC. It comprised of the Cincinnati Health Department, which was what we call the CCPC, Cincinnati City Primary Care Centers. We expanded from 5 to as many as 22. And then we also had a collaboration. This IVSN included the 8 community health centers. So the other federally qualified health centers that existed in the city of Cincinnati participated in the IVSN. We had the Christ Hospital. The Christ Hospital participated in the IVSN. What did it do? It provided enhanced access in terms of perinatal tracking. We had prenatal care consultation. We had the OBGYN that I referenced earlier on in terms of providing the OB obstetrical services and follow-up by the University Hospital. We had postpartum consultation, and our Cincinnati City Primary Care pediatricians that are in our health centers provided that type of consultation. We had home visitation, and we used the pathways approach in terms of skilled nursing. We had what is called care coordination. We had a community health worker outreach, and we had follow-up. We had health education and prenatal and postpartum health education, and this took place preconceptually all the way through 2 years. We had the WIC program, and we had referrals to the Cincinnati City Primary Care Centers, and we had, as I mentioned, preconceptual health, the prenatal, postpartum health education and data, and then we had a delivery report. Every month we had a delivery report, and there's a lot of detail in that delivery report, and so we got that monthly. Next slide, please. And so the surveillance data, what were you looking at and looking for in terms of this data? Obviously, the low-hanging fruit in terms of race, ethnicity, the prenatal care provider. What was the cesarean rate? The cesarean rate. Here's the story. Before we put this IVSN in place, we were within the health department, we were looking at and checking out what is the cesarean, what's going on in terms of vaginal deliveries and cesarean rate. And we discovered that there was a hospital that had a cesarean rate of roughly 45%, and the target for HP 2020 was around 23 or 25%. When we brought this to the attention of the hospital in terms of OBGYN department, they had no idea that they were having this level, this percentage for cesarean rate percentage. So additionally, we had a trimester entry of care. We knew exactly when that was taking place, and we also had the preterm labor. And so who participated? I mentioned who participated in the IVSN. So we had the University and Christ Hospital, but this is also important to note is that we had the Healthy Moms and Babes home visitation program, the American Mercy Nurses home visitation, as well as the Lighthouse Youth Services home visitation. Next slide, please. And so the team comprised of a nurse, community health worker, physician, social worker, and nutritionist. Next slide, please. And so for the city, as I mentioned, we knew exactly what was taking place in terms of within the health department. And so if we're going to address what's taking place outside of our health department clinics, what's going on citywide. And so what we determined, looking at where the deaths occurred in the city of Cincinnati, and 86% of the deaths occurred in these 19 zip codes. Next slide, please. And we also knew exactly which hospitals were delivering in those respective zip codes. So for here for these 24 targeted zip codes, the infant mortality rate overall was essentially 11.8 in those 24 targeted zip codes. And so when we squished it down, next slide, please. When we squished it down, we discovered that if we ruled out those zip codes that had a double-digit infant mortality rate, and by double-digit infant mortality rate, it would be anything higher than 9.9. So 10.0 constituted a double-digit IMR. A single-digit IMR was 9.9. Why did we select 9.9? Primarily because that was the target of 9.9 was our target in the sense that we wanted to have a single-digit infant mortality rate for the city overall, for the total city. So for those single-digit zip codes, the average or the total aggregate IMR for those zip codes that had single-digit IMR was essentially 7.6 through 2009, 07, 08, and 09. Next slide, please. For the other double-digit zip codes, the infant mortality rate was 20.7 for the aggregate. Next slide, please. So here we've determined that the single-digit zip codes, where they are at, and where the double-digit zip codes, where they're located. We also wanted to know which hospitals were delivering the African-American population And also, in addition, not only by race, but we also wanted to know their zip codes. Next slide, please. And so every week, we would monitor the actual number of births and deaths and what was taking place in these zip codes. So what this particular slide shows is that for the year 2013, we knew exactly what the infant mortality rate was at the end of the year, or not at the end of the year, but in terms of the actual availability of that particular data, because infant mortality numbers, they're provisional until you can actually verify them. But essentially, we were able to identify by zip code what the respective IMR was for a particular year and what had occurred in the previous year. Next slide, please. And so overall, you can, what this slide depicts is that from 2006, remember 2006, that year where the aggregate number for the city was 13.3. Overall, we could see that for those mothers, or the infant mortality rate that was that participated in the surveillance network, IVSN, the IMR was less than the city overall, period, through 06 through 2010. Next slide, please. And so what we decided to do is, with the infant vitality surveillance network being successful, and what could we do to more or less affect the citywide, is that we initiated something called the First Steps program. And this particular illustration depicts the First Steps program, where our goal was to focus on the 17 target zip codes. And those 17 zip codes were zip codes that had an infant mortality rate of at least 10 or higher, 10 or higher. And so our goal was primarily for the citywide, is to have 9.9 infant mortality rate. And so we knew to achieve a 9.9 infant mortality rate, we could not have more than 53 deaths, more than 53 infant deaths. So we calculated that out. So going backwards from our 13.6 number, calculating it out to get down to 9.9, based on the number of births that we've had in the past, we figured that we could not have more than 53 infant deaths. So what we put in place is, at the very top, you'll see in the middle cell where you have a rectangle, what that more or less represents is that when a mother goes into a hospital, one of the 3 hospitals that I mentioned, if that mother resides in a double-digit zip code, then that mother is going to receive an intervention while she's in the hospital. And that intervention that the mother is going to receive is that the mother is going to be asked, are you on WIC? The mother is going to receive breastfeeding education. The mother is going to receive a Edinburgh depression screen. The mother is going to also receive safe sleep education. And that mother is also going to be asked, do you have a medical home? And if they don't have a medical home, then we'll provide a medical home. Once that mother is discharged, which is illustrated by the arrow going to the left, once that mother is discharged, within 2 weeks of that mother going home, that mother is going to receive those same 5 interventions. A home visitation, one of our home visitation partners will go in and provide that particular home visitation and provide those 5 different education pieces. And if a person if they're not able to do the Edinburgh, then we have had our nurses at the health department go in and do the Edinburgh and the skilled nursing visits. Next slide, please. And so at the end of the year in 2013, to give you a sense as to what was the outcomes of that intervention in terms of the home visitation, is that 84% of the mothers, roughly 1,717 Edinburgh screens were made. 84% of our mothers received Edinburgh. 100% of our mothers received safe sleep education, and that represents 1,826 safe sleep education. Breastfeeding, 98.5% of the mothers received breastfeeding. That's roughly 1,700 persons. Postpartum appointment, 44.7%, and 65% of the mothers were assured a medical home, and 86.9% of the mothers received the WIC services. Next slide, please. Okay, so next slide, please. So here, in terms of what actually took place then, in terms of 2014, in terms of the infant mortality rate in those target zip codes. So for the hospital, one hospital, they had an IMR of 13.8, Hospital B, an IMR of 3.9, Hospital C of 10.1, and for those who were in the infant vitality surveillance network, the IMR was 8.7. Next slide, please. And what this slide more or less depicts is that just by solely going on the zip code, that could be misleading because it can mask what actually takes place in terms of a neighboring zip code. So in the Price Hill Health Center that I showed, that zip code is 45205. So if we just looked at just that one zip code, you could see that the IMR was 1.7. However, the contiguous zip code right next to it had an IMR of 6.9. But when you collapse that particular, those two zip codes, because they're right next to one another, then the IMR is 4.3. So what that meant for us is that we need to do some additional investigation in terms of that particular zip code in 45204. 45211 is a zip code that is in the Westwood community, and that is a working class white community. And now as more African Americans are moving in that particular community. The 45229 is a predominantly African American community, which is more or less upscale bougie community. Next slide, please. And so now we're more or less looking at, or want to take some time to examine, or at least address the prematurity percentage. Prematurity, here's the NICU, and Calista was talking about the neonatal intensive care unit. So we also want to draw your attention when you're thinking about this, what are the profit centers in a hospital? Where are the profit centers in a hospital? Is a NICU a profit center? So is there incentives for example, or to do a cesarean section? What is the disincentive there? If you're receiving greater, say, remuneration in terms of cesarean sections, that kind of a question. So one should also look at what are the cost centers or profit centers in a hospital. Next slide, please. So in prematurity and infant mortality, what we do know is that the leading cause of deaths in the first period of month is prematurity. It's also a leading cause in terms of the first year of life. And also premature infants are more than 15 times as likely than full-term infants to die in the first year of life. There are other complications which we could spend quite a bit of time on, but the issue in terms of behavioral, developmental delays and things of that nature, you know that, we know that. So next slide, please. We want to more or less draw attention to, okay, so what took place in terms of our attention if we receive these outcomes in terms of single digit in our health department, and then subsequently, let's see if we actually had similar results when we expanded the work that we did within our health department client population to the citywide. So here we have the percent of children born in premature by source of care. So the Cincinnati, the IVSN, the premature percentage for African Americans, 12.1, 5%, 6.5 for Hispanic, and for all births is 9.4%. The Healthy People 2020 goal for premature percentage during that period was around 11%. Let me check that. 11.4%. So the Healthy People 2020 goal is for premature percentage is 11.4%. So when we talk about these numbers, give you some frame of reference as to what is actually taking place. Also keep in mind, we're talking about folks who are working class, poor folks, essentially receiving and getting outcomes that essentially are in advance of the Healthy People 2020 target of 11.4%. So here, for those individuals outside who were in all other Cincinnati health providers for the African American population, 19.6 in terms of the prematurity percentage. Now remember, going back to the WIC program, the WIC program advantage, if you were on WIC, there was a negligible difference between white folks and white folks who were not on WIC and on WIC. But if you're on WIC and you're African American, you had a 8 point something or 8.5 IMR. And if you were not on WIC, the IMR was as high as something like 20 or 21. The punchline here is that you have an intervention, a public health intervention that's effective. You can have an extraordinary outcomes that achieve the targets for a population that is African American and also poor white folks, as you can see in terms of the population for the percentage of 5.0 for premature percentage. All right, next slide, please. So this slide more or less depicts that, okay, we looked at the prematurity in terms of prevention. So we've shown you what you see is the prematurity percentage. Now let's actually see what does that mean in terms of the actual preterm births. So we used 2009 as a baseline for the premature births that took place in our health department. So in the subsequent years, 2010, there's a 43 premature deliveries. So what that means is we prevented. We had 31 less premature births in 2010 than we had during our baseline for 74. So when you calculate those numbers out, just as I just showed you there, that for the roughly 6 years, there were 144 preterm births prevented. And as Calista mentioned, in terms of the costs that were incurred by her in the NICU, what we calculated out at the assumed average in terms of the cost of a NICU stay is roughly $150,000 to roughly $290,000. Those 144 births more or less rendered a savings of as low as 23 million to as high as 41 million. So the range was 23 million to 41 million dollars saved, not to mention the lives that were saved, as depicted in the low infant mortality rates and the not having a premature delivery. Next slide, please. So here, what we decided to determine, just as we looked at what is it that we needed to do, how many deaths did we need to target so that we can reach our objective of having a single digit 9.9 IMR for the city. We did the same thing in terms of hospitals. What can we do in terms of the hospitals? And what we computed is that if hospital A and hospital C more or less had 4 and 5 less deaths respectively, then the citywide IMR would be 6.9. And we figured that that is certainly an achievable goal, that for those two hospitals to have 5 less deaths than they had in the previous years, for us to reach a goal of 6.9 for the 20 Healthy People 2020 goal of 6.0. Next slide, please. And so it's also, given that we're in Pittsburgh sits in Allegheny County, in Cincinnati, we sat in Hamilton County. So we wanted to know, how were we doing in the city compared to how the county-wide was doing? And so we were able to subtract out and focus on the city and subtract out the city numbers from the county numbers. And what this slide shows is that from this period of 2009 through 2014, the city had 18 less infant deaths, or 17 less infant deaths than the county did countywide. So rather than have a masked number of having an infant mortality rate of this is what the IMR rate is for Hamilton County, ergo, and you're in Pittsburgh, here it is for Allegheny County, we really wanted to know what is taking place not only countywide, not only citywide, but also within the particular zip codes themselves, as noted. Next slide, please. And so as a result of that place-based surveillance and IVSN, as well as the First Steps program, we lowered the infant mortality rate from the 13.6 in 2006 through 2015 to 7.9. So we reached our single digit goals. So our goals, every year we would celebrate that the IMR, when we first received that IMR of 9.9, we reached that 9.9 goal. And so from 2006, that period, through 2015, citywide, now folks, citywide, 7.9 was the infant mortality rate citywide, and we were on our way to our target of the 6.0 target for 2020, Healthy People 2020. For the Infant Vitality Surveillance Network, again, the surveillance network, which is just solely the health centers and the federally qualified health centers, the IMR was reduced all the way down to as low as 0 in 2013. And from the last numbers that we were able to compute, to 4.5, where we actually surpassed or achieved the 6.0 IMR. So that's, my opening remarks, as I mentioned, in terms of you be the judge, in terms of not just advancing health equity, but achieving birth equity. Next slide, please. So the perinatal the maternal and perinatal system of care, identify and refer each expectant mother at point of entry into prenatal care, track that prenatal care visit through compliance, referrals, and follow-up, assess the risk at point of entry, and provide that nutritional screening for the WIC program. Next slide, please. And so a strategic overview would more or less look at what we included as a reproductive health surveillance data for the whole city, for the entire city, not just for the health department, for the entire city. The fetal and infant mortality review was put into place, and continued expansion of the community health worker program. It was vital to have community health workers in home visitation and have a measurement of those outcomes. And we also expanded the reproductive health and wellness program. And we had this pathway to ambulatory as obstetric as well as gynecological care. And of course, applying for grant applications. Next slide, please. And so the actionable evidence, and this is what Taylor was talking about yesterday, is having evidence. in terms of real evidence as to what you're doing in terms of our product, so that we assured the clients in the target zip codes that they had home visitation and that they were assigned a discharge, assured the clients in zip codes have home visitation during the prenatal care period, and we expanded the participation of the IVSN. And then lastly, next slide, and that is what we would call but we had a resolution. So the Board of Health had a resolution that more or less stated that this is our stance. This is the health department's statement of assuring, or at least making a statement that we are in support of health equity. And so we would certainly recommend that all of our entities, public sector entities, agencies, provide a similar organization statement or equity statement as to how they're going to achieve health equity for all. And in this particular case, reproductive health equity. So that's it.
Thank you. Thank you, Dr. Maseru. We definitely appreciate you sharing this amazing work. We do have time for a couple questions. So there is one in the chat. First question, can you explain to us why you use the term infant vitality?
Yeah, primarily, generally folks would be referring to infant mortality. And so we really wanted to put a positive, constructive, healthful kind of vision, anticipatory outcome, and look at not necessarily trying to prevent infant mortality, but we want to advance and promote infant vitality. So that's it.
Absolutely, definitely makes sense. So another question, at one point you shared a slide that had a long list of stakeholders and folks that it took to really get this work off the ground. So how did you go about gaining buy-in from all of these different entities to make this project successful?
Well, straight away, in terms of the IVSN, we were able to provide a demonstrated success through the health department. So that in of itself we were able to show that here are actual numbers of prematurity prevention. Here's actual numbers of what we're able to realize in terms of outcomes for mothers and babies in our health department. So number one, having demonstrated success, and folks who are also interested in the humanity and doing good work. So individuals and organizations who have a similar quest in terms of their vision for social justice, health equity, et cetera. That was the primary buy-in, is that we're not just providing an abstract, more or less touchy-feely, this is what we want to do. This is what we've been able to do. Here is some actual documentation. Come in, we'll show you the work in terms of sitting down with folks and showing the efficacy and the utility of surveillance in a place-based situation, and also having mothers and giving testimony that, okay, here, we are having a successful outcomes in terms of the nursing and what do you call it, the home visitation profession. So it wasn't just purely a physician kind of thing. This is really SDOH, social determinants of health, at real gritty, because there were home visitation agencies who would not go into certain neighborhoods. And so the nurses at the Cincinnati Health Department did that. And so being able to demonstrate and show, here is a population generally written off that's having these stellar outcomes. So that's how we got the buy-in.
Great. So this whole project was in Cincinnati. We're here in Pittsburgh in Allegheny County. So can you talk a little bit about what you would see as the starting point, or how something like this could be replicated here in Pittsburgh or Allegheny County?
Well, first, I would say that number one, community support and advocacy. So the work that Jada and her team are doing and have been doing here in Pittsburgh, expand that success. Let's get to the table. Let's have those entities that we know, for example, in terms of the hospital sector, the health department sector, at the table, and let's provide real commitment. And that commitment should first begin by looking at the data. What is the data? What is the actual work? What is the product of the work that you're doing in these respective places of service and care? I would also say, when we're talking about social justice, there are two features of social justice. One is equity, right? And so you want to make a determination as to, is there inequity in certain points or points of delivery and services? If there is inequity, what is disentangle that and identify where that inequity exists, okay? The other feature is democracy. That means essentially accountability. We got to have some accountability. There's advocacy. So in terms of the public sector, the public sector has a vital role in this particular equation or calculus for improving the health of mothers and babies. So that's why I mentioned that we had a $50 million budget, right? But we were accountable. That didn't just happen. I mean, we were accountable. We had to demonstrate it. There were council members who wanted to shut down the health department, but there were mothers in the community who refused to let that happen. And we were able to demonstrate by the cost, benefit, and savings that we're rendering to the community. So what is the public sector's role? And is that public sector living up to its responsibility in terms of accountability and delivery of services? 501c3s, they're valuable, but also it has to be done in concert with what's taking place in terms of the hospitals. What are hospitals also perpetuating inequality or inequity? So that's why I went back into that historical piece, because of the segregation and the racism and those kinds of things that exist there. We, just as Calista talked about what is taking place in being aggressive and attentive to what's going on in the NICU environment, we have to be aggressive in terms of what's taking place in terms of the environment for the provision of reproductive health services at the hospital level, health department level, and 501c3 levels. So that's the issue.
Absolutely. So there are two questions, and I know we're running short on time, so I'm going to ask them both and ask you to address them, and then we'll wrap up. So first question, it was a comment and then the question. The comment was, I love this so much. This is truly needed. The home program reminds me of a midwife and how traditionally they would come visit the family after birth. And so the question is, what do you think about nurse midwives or midwifery care in creating better outcomes? Second question, Dr. Noble, you have a deep understanding of the Black community and the well-earned mistrust for systems and institutions. As a public health professional, can you speak on the impact of our communities not being vaccinated at desirable rates in the intersection of infant vitality? So I know those are big questions and we're short on time, but we'd love to get your thoughts.
Well, first off, I just wanted to say that the Healthy People 2030 goal for IMR is 5.8 now. So I mean, so it's 5.0. I'm sorry, five infant deaths for 1,000 live births. Okay, so it was 6 in 2020. It's 5 now. All right. The point is that let's have accountability. If we're going to have hospitals, health departments, et cetera, let's have accountability in terms of what are they doing in terms of the outcomes of their mothers and babies. Get those numbers. That's one piece. The other piece in terms of the vaccination, in terms of under vaccination, let's get an understanding as to what are the actual numbers that exist in certain neighborhoods and communities. So for example, we know that for Allegheny County, the vaccination percentage aggregate wise might be 63%, okay? The target for herd immunity is 70%. We do know that in terms of positivity, the infection percentage for Allegheny County is roughly maybe around 0.09. The target is 0.05, right, for positivity. So we got to have a sense as to, for vaccination, if you're looking to determine, is it safe to go unmasked, okay, is that we need to have the information and the data. We know that in the African-American community right now, as we speak right now, Elise, is that the African-American community on an aggregate wise is 0.07 in terms of positivity. But guess what? For the white population is 0.09. So we're doing better than the white population, but we're still above the 0.05, okay, for positivity. So we need to be wearing masks, okay? And it has to be selective. Now for vaccination, that's what the original question was in terms of vaccination, in terms of what I would look at it in the sense of federally qualified health centers are key places from which we can have this intersection, if you will, which was used in terms of preventive primary health care, where you can get that type of service, holistic service in a community health center, all right? As we did in Cincinnati, we had a partnership or collaboration with the secondary care piece, which is your hospital. So your hospital is your secondary and tertiary care piece, but your primary care piece, in terms of preventive primary health care, is more or less your community health center, all right? So there should be some collaboration and partnership between your primary care, prevention providers, and that hospital. But also it means having data. What is the actual outcome or the efficacy of the intervention that's taking place within the hospital setting? I'm gonna say one more word, and then I'll be quiet because I know there's time, and that's lactation. Just as we went before the Allegheny County Board of Commissioners and said, look, folks, we need to have a mask, require folks to wear a mask. With the exception of a couple of folks, they said no. They voted no. We're not going to put in place a requirement to wear a mask. Lactation, breastfeeding. Hospitals should provide that lactation and breastfeeding. We should have lactation centers, certified lactation breastfeeding hospitals in Allegheny County, period. I don't know how many exist. If there are, y'all are more experts on that than I am, but that is essential that we have that particular service. That's the kind of collaboration that I'm talking about. If we're not providing lactation certification in the hospital setting for our mothers, then that's problematic. That's is essentially as problematic as commissioners for Allegheny County saying, no, we're not going to put in place a mask mandate when there's a pandemic going around.
Absolutely. And so I do see in the chat somebody is mentioning that Allegheny County Health Department has 2 programs that follow up with postpartum mothers. That could be a starting point for our postpartum mothers. And so thank you for sharing that. So Dr. Maseru, we appreciate you being here. We appreciate the information that you shared, and it would be great for us to figure out how to replicate the success of your program in Cincinnati here in Allegheny County.
It'd be easy. Just have people step up and say, okay, yeah, I agree with this, that, and the other, and let's do it. Put up your data. The Black Equity Coalition. Why do we have a Black Equity Coalition? Why is it necessary? Ask that question. And also remember, get the organization's stance on birth equity and reproductive justice. That's it. Sorry. Thank you,
No,
Elise.
don't
Had
be
to get there.
sorry. No, thank you so much. Those are great closing points. So we are going to take a quick break to transition and get into our third presentation of the evening. So we'll be back here at 6:05 for our next session, and we'll see you then. 1 second. Hey, welcome back. Thank you again for being here with us today. Just a quick reminder, please visit healthystartpittsburgh.org/infant health equity for the opportunity to give input about our action plan. There's a survey there. We'd love to get your feedback on the survey, and you can also register for our public input session that is happening on March 14th from 5:30 to 7. That'll be an opportunity to weigh in on our action plan. We are getting ready to move into our final session for the evening. We'll be joined by speaker Syreeta Gordon, and her session is called Nurturing Mom to Mom, Developing a Mom Helping Mom's Maternal Health Workforce that broadens access to care through fourth trimester support systems. Thank you so much, Syreeta, for joining us. We look forward to hearing from you this evening.
Thank you. So let me share my screen. Hold on a second. Okay, I'm so sorry. Where is it at? Okay. I'm trying to find the screen. Sorry. All right. So sorry, everyone. All right. All right. Hello. Can everyone see that? I don't know. Can you hear me? You're good? Okay. Okay. I just wanted to thank Jada Sherrill and Healthy Start for welcoming me into this space, and I thank your whole team for working this work. And you guys are making a great difference in what you're doing. And I also wanted to thank Pittsburgh Safer Childbirth Cities, WAM Global, and also the Rise High neighborhood allies that without them, I wouldn't been able to do this work. So I just want to thank them for sponsoring and being part of launching Nurturing Mom to Mom, the NurturHer app. So what we're going to dive into is developing a mom helping moms maternal health workforce that broadens access to care through the fourth trimester support systems. Just a little introduction, just welcome and thank you for inviting me again. My name is Syreeta Gordon, and I'm a mom. I'm a mom of four, two by birth, two by marriage, and I'm also a lead doula at an operating director at Kangaroo Birthing and Maternity Concierge. Kangaroo Birthing and Maternity is a birth doula agency, and we also have a fiscally sponsored arm through New Sun Rising called Unshakable Motherhood, which we're able to launch this project, NurturHer app. So through this, we were able to, we offer birth doula service, mother transition encouragement programming, and postpartum recovery lifestyle support. I wanted to start off a little bit about me and my story and my journey in getting here. because I feel like by getting you a glimpse of that, it will give you a better idea of why this all came about. I felt as if I bounced job to job. I was a college graduate, bounced job to job, and I didn't feel any career security or job security in the Pittsburgh community, which led me on an entrepreneurship journey. But it started off unconventionally through a mom blog and through writing in a mom blog and earning a little income from that. It led and snowballed to other opportunities where I was able to become a virtual assistant to other nonprofits and small businesses, which opened the door for me in the birth world. So I started working with nonprofits like Sister Saving Ourselves Now, that I began to lead programming with teen moms, and also another nonprofit where I worked in pregnancy care centers, where it opened my eyes to, I really was passionate about working with moms, doing the work, educating them. So I was just like so excited about doing this work. But one chance encounter with a birth doula, an African American doula that was a doula, and at the time I didn't know what a doula was, and she opened up an opportunity for me to work at the birth circle. So when I became an on-call doula, I was just hit hard with all these births, and it gave me so much experience that I was so thankful for. But then, I felt like in the middle of it, I became pregnant with a very high-risk pregnancy. And in that high-risk pregnancy, where I should have been on bed rest, but I continue to work because as a mom, we still have to do what we have to do. We still have to take care of our families, right? So I was still working, and through that unexpected pregnancy, where I thought, finally, dang, I really found my purpose. Now, what do I do now? But after one chance encounter again with the ultrasound tech, she said, why can't you continue this work? And that's what pushed me on to continue on into the birth doula world. Um, Looking back, I think this experience shaped the trajectory of my entire life. It opened my eyes by planting the seed for my commitment, by dismantling it, by saying there could be different ways to look at how do you work, and how do you, as a mom, put food on your table, because it dismantled how I looked at it, um, especially being catapulted into being a home business as being a birth doula, catapulted being a virtual assistant. It helped me to think out of the box, like how do I still earn an income for my family while still taking and being present in my family's life. So this is what led me on my journey to building the NurturHer app. And the mission of the NurturHer app is to establish a community of diverse women who support, exhort, and encourage one another along their motherhood journey. And the whole vision is to provide access to services and education to birthing and postpartum mothers at just one click. And I believe that it's going to create this value, as we are looking to provide one-tap maternal support that comes directly to you by providing education, by helping moms along their motherhood journey. Our mission is not only to serve women of color, but to support them through their birth, but to catapult more women of color into their God-given purpose. Because I feel like a lot of us Black women, we feel stuck. We feel stuck in our employment. We feel stuck in some of the um, responsibility of caring for our families. So as we strive to build up our families, we want to just build with through birth work, through this work, and as well trying to find consistency in work so we can have a more sustainable and viable income. And some of the problems that we faced, and I faced as a mom, was postpartum depression. I had what they call the baby blues, but there's different levels to postpartum depression. But as you can see the numbers there, like it occurs, 1 out of 7 women is the number one that that occurs in getting postpartum depression. And there's a stage which, you go past the mood swings and the tearfulness, but this occurs within the first week and it approximately lasts 6 weeks, maybe. And this is relatively common, occurring in 30 to 75% of women. The other problem is lack of prenatal support. As I pulled from a 2017 U.S. Department of Health and Human Service Minority Health report, about 10.2% Black mothers receive late or no prenatal care. Food insecurity, this is especially after the pandemic hitting. The 2020 feed report describes 1 in 5 residents are food insecure. So that means that not only as our growing children inside of us aren't properly nourished, our mothers that are carrying the children are properly nourished too. So that can lead to other imbalances. Then there, like I touched on just a second ago, is a large employment gap. So Pittsburgh Black women have a higher percent of their population that is left jobless than 97% of other peer cities, while African American mothers lag by 97% jobless than their peers in Pittsburgh. So these numbers were alarming to me, but I felt as if it was so familiar because this was something that I battled myself, and hearing from my friends and people that I've worked with that they were battling the same battle that I was in myself, because I wasn't alone in this battle. So the one picture or the story that or name that popped into my mind that put a face to this problem was Stanley Holbrook, where before the pandemic hit in 2019, she took her life, and my stopping grounds were where most of my time and raising my family was in West Mifflin Homestead. When I heard she jumped over that Homestead bridge, it hit my heart, and I read her story, and it hit me hard. And we don't know what caused Stanley Holbrook to take her life and to leave behind 3 beautiful babies. But one of the things I seen was that in her story was that her 1-year-old, her one child that was the newborn, he was a premature birth. And coming home with a premature birth and still having to take care of 2 other young children under the age, I believe, I think 8 or 9, if I remember her story. That was a lot. It's a heavy weight that any mom that has to carry. And we don't know what was going on in her particular circle. We don't know what weight she was carrying relationally in her relationship. We don't know what she was carrying as far as in her day-to-day work life. We don't know what was going on. And then on top of that, was she battling any postpartum depression? Was she battling postpartum psychosis? We don't know that. But putting a face to this work that we're doing, especially as we're working with postpartum moms, is that it leads the charge in like fueling our passion to keep reaching one mom at a time. And that if we just keep creating connections, creating collaborations, that we'll be able to reach the Stanley Holbrooks that are feeling hopeless, that are feeling alone in this battle. The solution, I believe, is having accessible help. The NurturHer app, the idea is that moms can access Mommy Concierge at one click and create a pathway to revive help whenever they need it that is easily accessible. Moms that are struggling and juggling maybe part-time jobs, or just mainly just trying to get their feet wet, or they a stay-at-home mom and they're trying to get their feet wet and just start to make a little bit of extra money for their household. This is a great opportunity for that, to provide to the work as much or as little as the mother wants to, the Mommy Concierge wants to. It gives mothers an opportunity to have a launching pad for work while raising their families. And we have this educational platform on there where we like to continuously create educational videos that are relevant to moms, and meet them right where they're at. That it could be both inspirational topics, like it could be infant care, stress management, postpartum recovery tips, interviews with those healthcare providers or mental health workers that can give them insight on how they could deal with what they're dealing with on a day-to-day basis. So what we do, as I said briefly, is that we provide Mommy Concierge, which is a lifestyle manager that you could select on the app. We provide pre-cooked family-sized meals that can feed up to 5 family members that are pre-cooked. You pop it in the oven. That is so convenient for moms that are coming home postpartum, that are tired, worn out from just having birth, and now they have to have the load of running their household when they get home. It doesn't stop, right? So having that pre-cooked meal ready for you, and you can just nurse your baby and relax and connect with your family. It also, like I said, we're going to provide short postpartum online video tutorials. We're going to provide laundry service at one click on there, that you could order laundry service, and that is another thing to help lift the weight off of postpartum moms. And transportation, because transportation is a big factor, that is a problem, and just getting back and forth if your child is in NICU, back and forth if your child, if you just got to go to prenatal appointments or mental health checkups as well. And just how it works, you'll just click on the app, and a mother will request a Mommy Concierge. And then the mother is contacted by the scheduler, usually me, and I'll receive the notification. The scheduler will assign the service a date and time to that they will receive, maybe the laundry pickup, or if it's just a meal drop off, to schedule that. A review is set out to the team, the Mommy Concierge team, and then they are matched with the mom, and as they are assigned, Mommy Concierge is assigned, and boom, they are delivered the service that they need. So, sorry. Okay. I'm excited about our team. It's been coming together slowly but surely. Like I said at the beginning of the presentation, with the help of the Rise High grant through Neighborhood Allies, we were able to add on more Mommy Concierge. And so with that grant, because when we beta launched it with the Allegheny County Health Department, I'm going ahead of myself. So we were able to, we were in high demand. So we didn't have as many as we liked. And then some of the moms weren't as available as we thought at the beginning of the launch. So it was down to 2 Mommy Concierge serving the family. So we had to raise the funds to be able to build a bigger team to reach the demand. So we have Marcia Danielson, which works remotely from Atlanta. She's on our app developer team. We have Taylor Clem, who is a doula in training with Healthy Start, and she also is a mother of 3, herbalist, plant and food enthusiast, that I feel that she's going to add so much of a wealth of knowledge on the tutorials on the app, as well as being a Mommy Concierge. We have Antoinette Watkins, who was a former user on the app that was so into what was happening, and she wanted to be involved with the mission. So she is also an early Head Start teacher, and she has that background and also she's a new mom of 1 as well. We have Naomi Chambers, that is a mother. She's also a great artist, and has an artist hub that she helps to run with her and her husband and that team. And she's also a Mommy Concierge. We have Natalie Dukakis that has been a part of the Kangaroo birthing team since day one, when we just provided meals inside of the birth doula packages that we had sold out. But as we began to grow, and then we developed the NurturHer app, we provide the meals also through the NurturHer app as well. But she's an educator, she's a mother, and she's a chef, and she is the business owner of Every Day's a Sunday on Pittsburgh's Garfield's North Side. Not North Side, I'll say Garfield. I'm from North Side, y'all. And we have Nadia Alameen, which she is a child care provider. She's also a doula, a trained doula, and she's also a licensed social worker, and she's a mommy concierge that's able to help out here and near on the app. So she's been pretty busy with building her new business, but she helps out here and there with the team. Oops. It went back. I'm sorry. Okay, I think I'm here. I think I'm in the right spot. Yeah. Okay. So what we like to call it is the 360 mom mom glow success path. So in that, we want to provide jobs. Moms who serve other moms will have access to flexible jobs. And we also want to provide jobs to doulas, aspiring doulas as well, because we believe that a lot of the doulas, as me being a doula, it feels like we suffer a lot from lack of referrals or lack of sometimes getting enough work, getting enough referrals and getting enough work to create like a sustainable business. So this could be a match on provide another service to other birth doulas. The other thing is, like I said, is to create content. There will be consistent content, updated video content that will teach and inspire various motherhood needs. We want to reduce overwhelm as we provide contactless service to postpartum moms that will break the household schedule by providing that support. And we want to build community. So the users will have access to an online mom community that's unlike Facebook. It will be a non-drama type space where we'll get to educate ourselves, connect with one another, and especially with other postpartum moms, we'll be able to have that forum inside the app as well. So our strategy has been, how will we reach the community? So there's different ways that we adopted how the app will be integrated into the community. And one of the greatest things is through partnerships. Partnerships like with the Allegheny County Health Department and their home visiting nurse program. They have been amazing. They allowed us to pilot this program within their program, and it's really gone over well. So we're going to go over the data in a minute. We want to create a transformative and healing environment that advances innovative efforts to address the community health and well-being of focused neighborhoods. We want to destigmatize the mental health concerns and trauma by continuing to build and grow relationships with other trauma-informed community development through these partnerships, health partnerships, and increase the standards and resiliency of the neighborhood based on economies, specifically commercial corridors, and investing in programs and initiatives that reach vulnerable small businesses, nonprofits that serve low income and Black neighborhoods. So like the last speaker, he really pressed upon data. Data is so important, and that's something that wasn't always my strong suit, but thank God for WAM Global and some of their teachers there. It helped guide me to understand the importance of it and how to gather it. We apparently have reached 30 plus users already on the app that they get notified through our email system when there's a new piece of content, a new video tutorial that's available on the app. The app has also increased in reach in providing not only app services, but also birth doula services as well that moms had wasn't privy to. And there was 15 plus we have served through that piloted through piloting it, and that's still growing now. We have served at least 15 plus so far, and families with that car, laundry, and meal service. Um, our highest in demand is the pre-cooked family meals, which one of our most highest in demand meal I just wanted to share is the salmon and vegetable meal. So that's the highest in demand. They really love the pre-cooked meals. And as a doula, when I first started out, they used to have these meal trains, right? You'll try to get your family involved to get the meals together for the mom that is expecting, that's going to give birth. But what if you don't have the support? So I feel like this is a great addition to a service to any mom or any doula that is trying to provide pre-cooked meals. The head of the household, which the age is usually younger moms between 24 to 25 years old that we reached, and we reached primarily African American women that was touched by the app. And so these are some of the testimonials that I wanted to share. And one of some of the user stories is that one of my first ever trips was to McKeesport to a particular mom that just had a baby, and she had three other children. And I was just supposed to deliver meals, but she wanted me to help her. She didn't have a car, but she wanted me to drive her to. I drove her to the grocery store just right up the street, which goes back to that food insecurity. Sometimes you just don't have the transportation to get to the grocery store that's right up the street. So she was so appreciative of what we delivered and what we were able to serve her with. And then there was also laundry insecurity, which there was a mom that didn't have laundry facility in her apartment, and she didn't have the money at the time. So the visiting nurse that referred us to her, she just had a 3-month-old, and she had children, like 4 children, all under the age of from 5, on. And you can imagine the overwhelm. And she had about 8 loads of laundry. And we did those 8 loads of laundry, and she was so happy, so appreciative when I delivered that laundry. And it, as you can imagine, that lifts off a household weight that frees her up to do whatever she needs to do for nursing her child, her newborn, or just to free her up, period. So, and one of the quotes I wanted to end with this is that it's connection. You would think with an app, like, how can you have connection? But this has been the most connected I've ever been to the community was through this app. As I began to serve through the app as one of the mommy concierge, and along with the other team members, and the community that we're building with the team that are also mothers, that we're voicing our frustrations, we're voicing our concerns with homeschooling, with just daycare struggles, all these different struggles that we're dealing with. But I feel like connection is key, and that we're lacking right now, especially after the pandemic has put this has attacked our connection, right, with one another, right? So I define connection, as Brene Brown had eloquently has stated, I define connection as the energy that exists between people when they feel seen, heard, and valued, when they can give and receive without judgment, and when they derive sustenance and strength from the relationship. And it reminds me of the time that this idea of the app was in seed form, when there was a particular doctor that was so passionate, she's still passionate, and she used money from a fund she had, and that paid me to take a particular mom, African American mom, back and forth to NICU. We will schedule her back and forth, and she had some healthcare concerns that I don't want to disclose. that she was judged harshly on within the NICU, and she would share the story of how she overheard some of the nurses saying things about her, and she voiced that in the car. She voiced her breastfeeding concerns, and I gave her some breastfeeding tips in the car on her drives home, on her drives to the hospital, to the NICU. And we built such a rapport and such a connection that I felt like it was like a lifeline for her during that short period of time when she was going back and forth to the NICU with her son. So all that to say is that I thank you guys for this opportunity, and I just hope that we can continue to build community together as you are building this town hall, and how to gather data so we can really solve the problems that we're seeing in our community. Thank you for inviting me, Kangaroo Birthing, and the NurturHer app. If you have any other questions, please feel free. You can just contact me. My contact information is at the bottom of the screen. Thank you.
Thank you so much.
Yeah, thank you.
So we have a question in the chat for you.
Mhm.
You okay? So as you hear, that's my little baby over here having a little cough. And first, I want to say I'm excited to have heard about your app and the work that you're doing, and I'm excited for those pre-cooked meals. So definitely looking forward to that, because you're right. Trying to manage it all and then still having to make dinner every night can definitely be cumbersome when you have a little one. So couple questions in the chat for you. So first, the person said this is a great program, and they're wondering how much collaboration you've done with some of the hospitals and birthing centers in the Pittsburgh area, and they name a couple. For example, McGee, West Penn, AGH, and Jefferson Hospital.
We haven't done that yet because we were tackling the problem and scaling, and we didn't have a big enough team. And now we just gotten to the point where we're able to hire a team now that we can count on. And I think now I'll be able to go out to those places to tell them about the app, because, before it was just, oh my God, like we had a high demand, as you can imagine. And then we were like, okay, it was just me and Nadia at one point. So it became overwhelming, but I'm grateful for the grant that we received at Neighborhood Allies. And we hope that it will come soon to those places, those spaces. Yeah.
And so in terms of the grant, so in the way that the service works, is it something that covers the cost for the mom, or do people have to pay? How does that work?
Yeah, right. Well, through the Allegheny County Health Department, they have funded a great portion. So you have to be referred to them, and then that's how some of that is paid for. And the other piece is with the Rise High, it will be funded as far as like for the driving back and forth, but the meals isn't so much covered. It's covered somewhat, but it's pretty tricky right now because we got a small budget with that right now. But that's why I'm just diligently trying to just trying to raise funding. We just got into a program called the Battery that I'm excited about. That it's like an accelerator program for startups like the NurturHer app, where we will be able to get access to how do we get more funding to keep this going. Yeah.
Absolutely. Another question in the chat. So this is so needed and will impact so many families. If other services are needed or requested by families, would you expand?
I think so, especially if the mommy concierge is open to it, and it's based off of, because I put it on them like you can work as much or as little as you want. If you want to work just that 2-hour trip, that's it, that's good. But as we grow the team, I think that it's that's going to be open to it, because I want to do that lifestyle management, that household management, like come into my house, organize something for me, that I would like to expand it to that, and see that connection happen between the mommy concierge and the mom. Yep.
Absolutely.
Mm-hmm.
Definitely, I'm sure there's just no shortage of support that you all could offer. So let's switch gears a little bit and talk about, you're a doula. And I
Mm-hmm.
think that we've read a lot and we see a lot about the benefits of having a doula, but I think there's still just a lot of just ignorance in terms of just sheer not understanding the role of a doula, or how a doula can be supportive throughout an entire birthing journey, prenatal, postnatal, and beyond. So, can you talk a little bit about that
Mm-hmm.
and how you're raising awareness in the community about the benefits of having a doula as part of the journey?
Yeah, I started out my journey doing that, where I did through IOB crowdfund, and also it was at one north, because I'm from the north side of Pittsburgh, y'all. And then like we did we got a small grant, the one north side grant, where I did small little workshops from Genesis Pregnancy Center to libraries, and sometimes online. I did like a live once on it. And then um I feel like I need to just expand online more, so to reach the community too. But we did what, like, workshop, what is a doula, because our community at that time, I felt like they didn't know what a doula was, just like I didn't know what it was until I started going into the deep into the birth work. And I wanted just to educate them on what we do. No, we're not a midwife. I think that was a lot of confusion that I had to keep explaining and unlearning, and say what we really do, and how we help in that process, and the power of having a doula. And I always, like with the doula team that I'm working with now, it's like, as we listen to the last speaker collecting data, and I say, always think about, like, what the difference a doula made. If you didn't come into that mom's life, like, what education did you give her before, like, that she didn't know before? Like, I feel like every doula does things differently. I feel like my philosophy is always, everybody's philosophy is different. I feel like you have to educate them a lot, especially during those prenatal visits. Sometimes as you're calling them and updating them with things, and like the stages of labor, like what to expect during the labor process, what pains are they going through in pregnancy, how do they combat, like, heartburn and things like that, these pains and things that they're experiencing, like. And the doula makes a difference, because we know these remedies, we share them with them, and it's up to them to implement them in their lives. And not only that, is that we pull the father in, because sometimes the father is like lost, as you imagine. You're like, I don't know what I'm supposed to do. And I always educate the dad of what's going on when you're hearing jargon in the labor room. And now I just implement comfort measures class. Like, I started, when the COVID lifted up, I started doing comfort measures, where we did the different pain techniques and things like that in the home. And they're just, it lifts off the fear. Like, I feel like with labor and birth, there's so much fear associated with it. And I told them it's always mind over matter. And like, and going through the comfort measure techniques and pulling the dad in, and how you can comfort your partner, it makes it just sexy. It makes it like a different experience. You know what I mean? So they're not afraid of it anymore. They're like, oh, okay, this is what it's about. Then you just educate them how much is how much is a dilation of this or that, what is pitocin, what is this, what to expect when you're getting induced, like, and all these different things. So, like, I can go on and on, but it's like, that's how I would put it. Yeah. Yeah.
Absolutely. And those things are absolutely important, especially to be thinking about in advance, because of course, when you get to the point of labor, your mind and your body are in so many other places. So having some of that up front is definitely helpful. Another
Mm-hmm.
question in the chat. There are other birthing centers in the Pittsburgh area, especially among the Black doulas. what are the possibilities of collaborations and sharing resources?
Collaboration with the other birthing people, you mean, or what do you mean?
Um, so I don't know. I would ask the person in the chat to maybe clarify. Is it, so are you talking about collaboration among the other Black doulas? I would assume so. And
Yeah,
then how to share resources. But feel
this is
free
something.
to
Yeah,
follow up in the chat.
this is something that we are working on now, especially in the space of WAM Global and Pittsburgh Safer Childbirth Communities. I'm gonna just name drop Ilana, the Birthing Hut is in that circle. Maya, my organization is in that circle. Elephant Song is in that circle, and we are in the prenatal champions right now. They created this group where we're going to really break down these barriers and try to figure out how can we collaborate, how can we effectively as Black doulas like come together and really make a difference in our community. Like I feel like there's been a lot of um how can I put it, it's just not been working like that. There wasn't a lot of unity there, but I feel like now the conversation is starting. I'm looking at the positive more than the negative, and I just want to put the negative behind me. And what are we doing now? How are we going to combine resources? Just like a mom told me today, it's like when I went to this one birth center, I forget what hospital, they had not nary Black organization, Black doula listed on there. And we need to, with the champions program, I hope that this is something that we could change. You know, why aren't there any Black birth doula agency listed? That's crazy. So we just gotta try to slowly make changes like that.
Absolutely. So we have a few more minutes, so feel free to continue to put questions in the chat if you have them. And we'll go from there. Just some comments that are coming up in the chat. Just talking about some of the fear associated with the childbirthing process and just the need for more doulas. And then a comment about looking at negative images of birth that we see on TV growing up. You know, I definitely, think that that my perspective of what to expect and how it was going to go, and the water breaks in the car, and next thing, the next scene you're holding your baby. I mean, definitely images that gave us a completely false idea of what that would look like. And so that level of education is absolutely important. Definitely some people talking about just the excitement around collaborations, and how
Yes,
critical Black doulas are in the county as well.
it really is. I'm excited about the change because I feel like it's been a renaissance happening, especially after, I hate to say, with Black Lives Matter, that shocked all of us when that happened, like in our face. Like, I feel like it forced everyone to take a different view on how are we going to make changes. Like, because even though we made some changes, we got a long way to go. We really do in our community. And I just hope that, as I know, I'm like, especially with New Sunrise, we've been taking these like self-care workshops and leadership workshops, and how do we better take care of ourselves? What inner work are we doing with ourselves? It starts with us, and then as we start to get better, that trickles out to who we're serving. Because if we're not good, we can't give, we can't pour out of an empty cup, as you always hear. We can't pour out of an empty cup. So that's one of the things that I'm so passionate about, is that inner work, because that's part of it. Especially doulas, we can get burned out and quit. And one of the things I feel like the pandemic taught me was how to rest. Like, don't go. No, it's important to take time to rest, to recalibrate, to think about what just happened, what was good, what was bad, how do we address that going forward. And I think that's so important. Like, and having the difficult conversations, right? Like with people that we try to avoid. like that's all a part of it, you know? So that's part of that healing. So, yeah.
Absolutely. So as we wrap up, I'd love to give you the opportunity to just share some final thoughts and also to just remind us how we can get connected. So share the website, how we're able to access the app. That would be
Yeah.
great.
Well, do I put that in the chat or
You can tell us and then we'll
oh
make sure
yeah.
the information gets in the chat as well.
Yeah, you can reach us at kangaroobirthing.com and reach us kangaroobirthing@gmail.com. The app is web-based, so it's not like Google Play or all that. It's web-based, so it's like a link. So I can shoot you, I don't know, I could shoot you the link. It's like a link. So right now, it's like we're going to develop it. I feel like as I go into this program, the battery, it's going to develop it to the next level, like that I needed. But this was like, this is just the beginning, you know. At least it's formed in a way, you know what I mean? So it's just the beginning, you know. So yeah.
Absolutely. Very exciting work. Thank you again, Syreeta,
Thank
for
you.
being here and for sharing. We definitely look forward to the expansion of Kangaroo Birthing. It's absolutely a much needed service here in the region and absolutely beyond. So thank
Thank
you
you
again
so
for being
much.
here.
Yeah.
So
Thank
as we come to an end this evening, we want to remind you again to visit healthystartpittsburgh.org/infant health equity. You can take the survey about our action plan, give some input about the plan, and then also sign up for our public input session, which will be on March 14th from 5:30 to 7 p.m. That'll be an opportunity to view the plan and to provide some input as well as we move towards the submission and the launch. Be on the lookout for information about the launch event. We'll be launching the plan the week of April 11th, which is Black Maternal Health Week. So we'll be sharing some information about that shortly. And then you'll also be able to revisit all of the sessions from our town hall. So we'll make those available so that you can catch these sessions again if you've missed them, or just to go back in and share or to revisit all of the wonderful resources that were shared with us over these past 2 days. So thank you again for being here. We appreciate your time and attention. And thanks again to all of the panelists and presenters who shared their amazing stories and the work that they're doing to promote infant health equity. Have a great evening.